Okay, this is the 13th gross specimen. Today we are continuing with the gross specimens of the first year. Can anyone discuss this? What do you think this is? Am I audible? Are you hearing me?
Yes, sir.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Then please give your opinion in this gross picture. Any one of you. No matter whether you are right or wrong, whatever you have seen, just say that.
So carcinoma colon proximal.
Very good, very good. So why do you think this is a carcinoma colon?
Sir, there is a large ulceroproliferative growth that is invading into the lumen.
Okay.
Uh,
Okay, that is the most important characteristic feature. See, here you can see, is my pointer visible?
Yes, sir.
Okay, then here you can see, this is the normal mucosa of the colon. So just here after this area, you can see here there is a mass, which is a ulcero. Here is the ulceration, and here is the proliferative cauliflower like mass. Okay, so here this is a ulceroproliferative mass after this normal area, normal looking area. Okay, so this is the ulceroproliferative mass in the part of the colon. So it is and it will be invading into the wall of the colon. So I know that you know the layers of the GI tract, including colon. Yes? If this will be the mucosa, then there will be submucosa, then there will be muscularis propria, then there will be serosa or adventitia will be there. And variably, this tumor will be invading into the wall, and it might go out to the other structures of the body. So here we can see a ulceroproliferative mass. So identification points you have to write. This is the specimen of a part of the colon, and cut section shows large ulceroproliferative exophytic growth on the mucosal surface projecting into the lumen. And the growth has heaped up margins and ulcerated central portion with necrotic areas, and the growth is seen extending up to the serosa. Here we are seeing this photograph from the front face only, not from the side face. So we can't see up till where the infiltration of the tumor is. But here we know that there is a tumor which is ulceroproliferative with central ulceration and necrotic area and heaped up margin with irregular tumor. So this is a carcinoma of the colon. And which type of tumor, which type of carcinoma is this most commonly? Which type of carcinoma will occur most commonly in the colon?
adenocarcinoma.
Very good. So you should not take time to tell adenocarcinoma, because this is wherever there are glands normally, then adenocarcinoma is the most common tumor. Wherever there is a squamous lining or a metaplastic squamous lining, then there will be squamous cell carcinoma, like in the skin or the cervix or the larynx. Okay, so these are the areas. This colon normally also will have columnar lining and the glands. So most commonly adenocarcinoma will be the malignant tumor arising from colon. So what is the benign counterpart of adenocarcinoma and what is napkin ring? So you should know this. I will go to the question. Like there will be a question like this. A 74-year-old man came with rectal bleeding. So if it is a carcinoma colon, then there will be a rectal bleeding. and specimen of the colon is shown, which is obvious. Well, write down your diagnosis with 2 identification points, which we have already discussed, and list the 2 morphological types. So the morphological types will be proximal type and the distal type. The proximal type will have polypoidal exophytic ulceroproliferative mass or cauliflower-like growth, whereas the distal type will have annular lesions producing napkin ring-like constrictions. Okay, so if a patient has a proximal type of colon carcinoma, then the patient will present with a rectal bleeding. But if the patient has a distal type of rectal carcinoma or a colon carcinoma, then there will be annular lesions producing napkin ring-like constriction. So whenever there is a constriction, then the patient will not pass stool. Then there will be constipation. The patient will present with lack of, or the patient will present with constipation for many days. So the presentation will be different in these 2 types. This you should know, either it is a proximal type or a distal type. So if it is a distal type, then it will present with constipation. So chances of early detection is more in case of distal type of adenocarcinoma. Gross number 14. So this is also a colon. Can someone tell this? What is it? Unmute yourself and just describe this gross specimen, please.
Sorry, distal carcinoma colon.
Okay, distal carcinoma colon. So what are the features in favor of that diagnosis?
So there is circumferential growth that constricts the lumen, and
Very good.
area proximal to the growth is dilated,
Very good.
and napkin ring appearance.
Very good. Very good. So this is the area of constriction. Okay, this is the area of constriction, which is the tumor. So there will be circumferential tumor, which will constrict the lumen of the colon. So what happens is the stool will come here, feces will come here, and they can't pass through this area, towards the distal area. So it will, what happens? It will dilate towards the proximal part, whereas distal part will be normal. So here you can see this is the stressed type of mucosa, whereas this is the normal mucosa, and this is the tumor area, which is like a napkin ring like constriction. So this is the distal carcinoma colon. So you should write, this is the specimen of a part of a colon showing circumferential growth constricting the lumen of the gut, and the part of the colon distal to the growth is normal, while the proximal part is dilated, and the mucosa of the proximal dilated part appears thinned out. Why it is thinned out? Why is the proximal part of the colon is thinned out? Mucosa of the proximal part?
So due to stretching, due to the accumulation of the feces.
Okay, very good. There is a constriction so the feces can't pass through that constriction to the distal part. So the proximal part, there will be dilatation, and so because of this dilatation and the stretch, there will be thinning out of the mucosa of the proximal part. So you should be very clear with this. The proximal type of colon carcinoma and distal type of colon carcinoma. Kushal Kesi. Kushal Kesi.
Good afternoon, sir.
Good afternoon. Can you please tell what are the differences between the proximal and distal type of adenocarcinoma of the colon or carcinoma of the colon?
So, in case of distal, the proximal portion is thinned out.
Okay.
So, both sir, there is napkin formation, napkin ring formation.
Napkin ring formation is present in which? Not both types.
In the distal one, sir.
Okay, distal one. And what about the proximal one?
So, in proximal, there is ulcer proliferative growth.
Okay, very good. Okay, Sakshi Ja.
Yes, sir.
Can you please elaborate on the proximal type of colon carcinoma, gross? Whatever we have discussed? Or shall I show you the picture? This is the picture. It must have come into in your screen. So how do you describe this gross?
So there is napkin ring appearance.
Sorry, can you repeat, please? I can't hear you properly. Okay, Susan Gimire. Susan Gimire. Some of you are leaving the meeting. I can know that whoever is leaving the meeting, we can know when and for how much time they are leaving the meeting. So do not leave the meeting and be there, stay in the meeting. Okay, then we'll move ahead. We have talked about the identification points of the proximal type of colon carcinoma. A question might come like this. 72 years old man presented with a large bowel obstruction. So whenever there is a large bowel obstruction, you should think of a distal type of carcinoma colon. And the bowel obstruction is due to the napkin ring-like constriction of the part where there is the tumor in the distal part. So what is the diagnosis? And write the two causes of this constriction. Write the two causes of this condition. And what is napkin ring growth? So you have to write this. Okay, this is the 15th gross specimen. Can anyone please discuss this? You can describe whatever you have been seeing this.
The gangrene of intestine.
Okay, very good. Gangrene of intestine. So what are the features in favor of the diagnosis?
So well demarcated gray black area.
Okay.
The normal bowel.
Okay. So here you can see
And the
there is a
coagulative necrosis.
coagulative necrosis. Okay. So can you tell me what do you mean by gangrene? What do you mean by gangrene? You are
Sir,
talking
dead
about...
tissue.
Okay. Anyone else?
So necrotic tissue due to lack of blood supply.
Okay. So
Necrotic tissue plus putrefaction.
plus?
Putrefaction, sir. Decomposition. Like.
Okay. So mostly in gangrenous necrosis, it is not a peculiar type of necrosis. So what type of necrosis will be there in gangrenous necrosis?
Coagulative.
Coagulative necrosis will be there. So what are the features? Again, can you repeat in this specimen, in this specimen, in favor of the diagnosis?
Sir, there is well demarcated gray black area.
Okay.
Answer, the bowel is normal.
Okay. So here you can see the gangrenous area, which is the brownish black or dark. Okay. Here you can see a well demarcated area from where we can see the normal bowel is there. So it is a specimen of a portion of the intestine where a well demarcated gray black area is seen, and there is involvement of the all layers of the bowel. So this is the front facing photograph, so we can't see from here whether all of the layers are involved or not. But in the exam you have to write there is involvement of all the layers of the bowel. So in the exam you have to write there is involvement of all the layers of the bowel, and a portion of the normal bowel is seen in the lower part. So you have to write these things. And questions for discussion can be: name the two types of gangrene and give examples of each. You have to write about dry gangrene and wet gangrene and the causes for this. So a question might be: a 24 years old man comes with acute pain abdomen, specimen of the intestine is given. Write a diagnosis and mention the two identification points and mention one cause for this condition. So diagnosis, it is gangrene intestine. Identification points we have already talked about, and what can be the causes for this condition? Can someone say?
Ischemia.
Okay, ischemia. And ischemia can occur due to which conditions?
Thrombosis, lack of blood supply.
Okay, thrombosis, embolism, atherosclerosis. Okay, so whatever leads to obstruction of the blood flow to that area, those are all the causes for occurrence of this condition. Okay, like thrombosis, embolism, atherosclerosis, these all are the causes. So this is the gross number 16. Anyone please describe this? Please describe this gross specimen.
It is a benign counterpart of smooth muscle cancer neoplasm, in which there is well circumscribed mass of smooth muscles which are proliferating.
Okay. Here, what can you see?
A specimen of uterus.
It is a uterus.
Okay, it is a uterus. The first thing is you have to identify the specimen. Okay, either it is a breast or it is a colon or it is a stomach or it is a... So that should be your first identification. Okay, so this is a uterus. So in the uterus, what can you see?
In the muscles layer, we see the neoplastic tissues, which
What
are
is the muscle layer of the uterus called?
myometrium.
Okay, myometrium. You are talking about this, right?
Multiple nodules.
Yes. Here there is a module or modular growth in the myometrial layer and submucosal layer also, submucosal area also. Okay. So what you can say is this is the specimen of the uterus showing multiple gray-white discrete nodules in the myometrial wall. If it is present in the myometrial wall, then it is known as intramural area. Okay. And underlying the endometrial cavity, if you can see like this one, it is the submucosal. If it is a leiomyoma of the uterus, then there can be intramural occurrence, submucosal or subserosal. These are the three anatomic locations or anatomic types of the leiomyoma. Okay, if it is in the myometrial wall, inside the wall of the myometrium, then it is intramural, inside the muscle. Mural means muscle, okay, or the wall. So intramural. Underlying the endometrial cavity, below the endometrial cavity is submucosal, and on the serosal surface is subserosal of the uterus. And the cut section of the nodule show whorled appearance, gray-brown to gray-white areas. So here you can see all the three types of leiomyoma, occurrence of all the three types. Here you can see this is the intramural, which is within the muscle. Here you can see a smaller one. Here you can see it is the smallest one. Here it is another one. So this is the submucosal, and here you can see this is the subserosal. So within the muscle myometrial layer, this is the intramural. This is submucosal below the endometrium, and towards the serosal, this is the subserosal. Okay. And cut section. Can anyone describe the cut section? There will be whorled areas of gray-white or gray-brown areas, and you should not miss this whorled appearance. So the question will be 40 years old female had history of menorrhagia since 3 years. Hysterectomy was done. What is the diagnosis and what is the malignant counterpart of this tumor? So we know that this is leiomyoma uterus, and the malignant counterpart of this tumor is leiomyosarcoma. Is this clear till now?
Yes, sir.
Today we talked about till now 3 gross specimen: carcinoma colon, the proximal part, proximal type, and the distal type, and the gangrene intestine, and this is the 4th one, which is the leiomyoma uterus. Now we are going to this specimen. Can someone describe this, please?
Melanoma skin.
Okay, very good. Melanoma skin. So why do you think this is melanoma skin?
So first, the specimen of the skin.
Okay, this is a specimen of the skin. Very good.
We see discrete black nodules popping out of the skin, and we see a small satellite-like nodules beside the.
Very good. Very good. And is this lesion regular or irregular?
It is irregular.
Okay. So what are the other features that that can be in favor of melanoma? Do you know the ABCDs of melanoma?
It should be asymmetrical.
Okay. What do you mean by asymmetrical?
So if we caught the tumor from with we cannot cut the tumor in 2 equal halves from any plane.
Okay, those will be different. If we
Yes,
cut also that those will be different. Okay, that is asymmetry. And B is
the diameter is more than
B.
5 centimeters.
B will be
I don't remember, sir.
C.
Restless thickness.
Color. There will be change in color.
Okay, change in color. D.
So the diameter.
Diameter. All of you know this? Some more voices. I hope you are not sleeping.
So is it boundary for B?
Sorry? Yes. Boundary will be irregular.
Yes.
So what is the counterpart of malignant melanoma, benign counterpart? It will be mole or nevus. So you should write this is a specimen of skin and there is a nodular grayback tumor which is seen, which has asymmetrical, the tumor is asymmetrical and it has irregular borders, okay? And there is a presence of a satellite nodules. Here we can see this is the main or the primary tumor, and apart from this tumor there are two smaller lesions just adjacent to the tumor which are the satellite nodules. So this tumor is black, brown, okay, dark, and it has variegated appearance. There is no uniformity in color throughout this lesion, and it has irregular borders. So this is definitely a malignant lesion, and it is a melanoma. Question can be 56 years old female noticed increased itching in the pre-existing mole. So on examination, it has an irregular border with different parts showing varied pigmentation. So what is the diagnosis? You know, malignant melanoma or only melanoma. These two things, either you can say malignant melanoma or you can say just melanoma. These are same things. And write the two important microscopic features. So here the gross is given and you are asked to write the microscopic features. So you should always see the question properly. Okay, anything can be asked. This is just an example of a question. So here, what is the diagnosis? Diagnosis is asked and write two important microscopic features. So you have to identify the gross and then write the microscopic features. I hope you are clear till now. Is it clear?
Yes, sir.
Any questions? Any confusion, any question till now? We can discuss. Okay, if not, we'll go ahead. We'll continue. This is the 18th gross. So, can anyone describe this?
Secondaries in the liver.
Okay, very good. Is this Suryaraz?
Yes, sir.
So, can you tell me why you tell this is a specimen of secondaries in the liver?
So the specimen is of the liver, and we see different metastatic nodules.
Okay.
Small nodules in the specimen.
Okay. Okay, this is a liver. This is the liver parenchyma. Here you can see this is a liver. Okay. And there are multiple small and variable sized nodules which are present in the parenchyma of the liver. Okay. There are multiple small deposits in the liver which are whitish to slightly brownish. Okay. So these are the nodules which are embedded in the liver parenchyma. So these are the metastatic deposits of tumor in the other part coming to the liver and getting deposited. So can anyone tell what are the routes of metastasis?
So it could be hematogenous route, lymphatic route,
Okay.
or the body spaces or body cavity.
Okay, and it can be direct.
Yes.
Okay. Here you can see this is the specimen of the liver, and on cut section multiple gray-white small nodules of metastatic deposits are seen. So questions can be, what is the route of metastasis in this case, and name 3 sites from where metastasis can occur in the liver, and how do you differentiate this specimen from primary carcinoma of the liver grossly. So can anyone tell how do you differentiate this from hepatocellular carcinoma or primary carcinoma of the liver?
So secondary, there is multiple foci, but in primary, there could not be multiples.
Okay, very good. Very good. Here you can see multiple small, okay, multiple small nodular lesions. But in primary, there will be either single or few lesions will be there. That is the most important difference. So you have to see the question. A 60-year female presented with lump in the left breast. Okay, here the breast lump is there. On fine needle aspiration, malignancy was confirmed. Okay, FNAC was done, fine needle aspiration, and it was confirmed as malignancy. She was put on chemotherapy and died after 3 months. And post-mortem specimen of the liver is shown here. So identify the lesion and mention the different routes of spread of malignant tumors. So we have already discussed about these things. Lesion is metastasis in the liver or secondary is in the liver, whatever you can see. The routes of spread of malignant tumors are direct seeding of the body cavities or surfaces, lymphatic spread, and hematogenous spread. So this is the another gross specimen. Can someone describe this, please?
Teratoma.
Okay. Any other person? Anyone else? Okay, I want to hear from Suraj Acharya. If you are there, if you are not sleeping.
Yes, sir.
Okay, I'm happy that you are here. Can you please tell us what is this specimen? Just tell us the name. One of your friends told that it is a teratoma. So do you think this is a teratoma?
Sir, dermoid cyst of ovary.
Okay, dermoid cyst of ovary. So do you think, Shreya, what is the other name for dermoid cyst of the ovary?
Sir, don't know.
Teratoma. Okay, which type of teratoma is this? Which type of teratoma is this? Is this immature teratoma or mature teratoma?
So mature.
Okay, mature cystic teratoma. Here you can see the ovary is enlarged with a cystic space. Okay, and here you can see some tooth. Tooth is there. Okay, here is there, and you can see some ischemic changes. Okay, with the wall of the ovary is blackish or dark, dusky. This is the specimen of the ovary with wall of the cyst is thickened with smooth inner lining and shows a gray-black discoloration as the result of the torsion of the tumor. So there is ischemia, so there is gray-black discoloration. Okay, and the cut section of the cyst shows firm protuberant area with teeth and hair. So this is known as Rokitansky protuberance. So this particular area, this protuberance is known as Rokitansky protuberance. Otherwise, there will be some potassious material, okay, like this, and there will be here, and there is presence of tooth also. So this is a mature cystic teratoma or dermoid cyst of ovary. So a young female presented with left ovarian mass, what is the diagnosis, and give two identification points. So you can do this. What is the diagnosis? It is dermoid cyst ovary or mature cystic teratoma ovary. Give two identification points. We have already discussed about that. Okay. Can we discuss this? Gross number 20. Anyone? Please describe this.
Sir, osteosarcoma.
Okay, okay, very good. Osteosarcoma. Why do you think this is osteosarcoma?
Sir, gray white area.
I am getting echoes. So can you please repeat slowly?
There is gray white area.
Okay.
Sir, there is hemorrhage and necrosis.
Okay. So whenever you talk about a malignant tumor, there should be a mass. Okay. Here you can see this is the part of the knee where you can see the tibia. This is the distal part. Okay. Here's the skin and here is the joint part. Here you can see the tibia and here you can see the distal part of the femur. But here you can see there is a large bulky tumor. Mass is there, bulky mass. Do you see normally do you see this type of mass? No. There is a bulky tumor, okay, and areas of hemorrhage and necrosis are also there, which you talked about. So you have to say this is the specimen of the knee joint with surrounding soft tissue is there, and there is a metaphyseal tumor arising in the lower end of the femur. So here you can see there is no tumor towards the tibial side. The tumor is in the metaphysis of the lower part of the femur. So here the tumor has a gray white appearance with focal areas of hemorrhage and necrosis is there, and extensive cortical destruction and extension into the adjacent soft tissue structures producing a soft tissue mass. Is this clear? So in this specimen, there is a gray white mass which is arising from the metaphysis of the distal part of the femur, and it is invading into the surrounding soft tissue. See here, and there are areas of hemorrhage and necrosis. Although due to the fixation for a long time, we can't see those areas, but here you can see areas of necrosis also. So what is the cell of the origin? So you have to know these questions. What is the cell of the origin and what is the benign counterpart of this tumor? You have to go back and study your logbooks, practical logbooks. So question can be 14-year-old girl developed painful mass in the right knee. It is progressively increasing in size. So what is the diagnosis and write to identification points. So we can write this. So what is Codman triangle? Can anyone tell what is Codman's triangle?
So due to the extensive growth of the tumor pushes the periosteum of the bone and creates elevated periosteum and angle.
Okay, that is because of the elevated periosteum. Okay. Gross number 21. Can anyone describe this?
Gangrenous foot.
Okay. This is gangrene foot. Why this is gangrene foot? Okay, this is a specimen of a foot. Why this is gangrene?
Well demarcated gray-black areas in the toes.
Okay. Again, the same thing which we had discussed in the gangrene of the intestine. There will be, if it is an area of gangrene, there will be the well demarcated area from the normal looking tissue. Either it is the leg or the intestine, part of the intestine. Okay. There will be a, this is the specimen of a foot, and the big toe and other toes show well demarcated gray black area, and other areas of the foot appear normal. So the questions can arise: what type of necrosis is seen here? What is gangrene? And what is the commonest cause of gangrene foot? And a question in the practical might come of 65 years old male diabetic person came to diabetic clinic of our hospital with history of pain and discoloration of the foot. Identify the lesion. So identification is gangrene foot. Okay. And next question is list 2 more complications of diabetes mellitus. So this gangrene foot occurs as a part of complication of the diabetes mellitus. Now 2 more complications are asked. So what are the 2 more complications of diabetes mellitus?
Diabetic nephropathy.
Okay, diabetic nephropathy.
Diabetic ketoacidosis.
Okay, diabetic ketoacidosis. Diabetic retinopathy. Anything can be there. Okay. Microvascular complications, macrovascular complications. So you have to divide, but here you just have to list 2 more complications. You can just write 2 names, diabetic nephropathy and diabetic retinopathy. Okay. This one, gross 22. I hope I think this is the last one. Can anyone describe this? No, this is the second last one. So here you can see, here is some tumor. Is it normal bone? This is a specimen of a bone. Yes? Are you convinced?
Yes, sir.
Okay. Then if you are convinced that this is part of a bone, okay, here is some tumor. This is the specimen of a lower end of tibia where there is eccentric epiphyseal tumor with extension to the metaphysis. Okay, epiphyseal tumor is there with extension to the metaphysis, and cut section of the tumor shows heterogeneous appearance with gray-brown hemorrhagic areas and few areas of cystic changes. Here you can see there are some tiny cystic changes. Okay, epiphyseal tumor going to the metaphysis, and the cortex appears thinned out, and the articular cartilage here in the lower tibia, it is intact. So question might come: a 40 years old lady complained of a swelling near the left knee. Amputation specimen is shown. So what is the diagnosis? And mention 2 typical radiological features of this lesion. So we know that the diagnosis is giant cell tumor. Okay, it is a giant cell tumor. And radiological features, can anyone tell?
The soap bubble appearance.
Okay, very good. So bubble appearance, and there will be a lighting.
elevation.
Sorry.
No periosteal elevation.
Okay, no periosteal elevation. That is a negative feature. And there will be lytic tumor. Okay, lytic tumor with soap bubble appearance. It is almost diagnostic of giant cell tumor. So gross 23, last one. We have few minutes left. Can someone discuss this?
Chondrosarcoma.
Osteochondroma.
This is chondrosarcoma. Okay, this is a section. Sorry, this is a gross which shows a large lobulated tumor mass. Multiple nodules of glistening, translucent, gray-white cartilaginous material is seen. Here you can see multiple lobulated areas which are cartilaginous, okay, which are glistening, translucent, and gray-white. These are not transparent but translucent and gray-white. Lobulated area is there definitely. And cut section shows focal chalky areas of calcification. So chalky areas of calcification can be there. The question can come, a 70-year-old lady came with a swelling over the hip bone. What is the diagnosis? And write 2 points of identification and name the benign counterpart of this tumor. So we know the diagnosis, it is chondrosarcoma. Write the 2 points of identification. We have already talked about that. And what is the benign counterpart? Chondroma. Okay, with this we have finished the gross specimens. So from next practical class, we'll start the slides, microscopic slides. You have to take participation in this practical class. You can't stay silent. Either you are wrong or either you are right. You have to talk so that you will have some practice for the exams. Okay. If you are wrong, we will correct you. So is this clear for today?
Yes, sir.
Okay, if you have any problem, you can ask during the next class also. Okay, so for today, if it is all right, then we'll leave. Thank you.
Okay, sir. Thank you, sir.